Okay, I'd like to welcome everybody to the VITL Summit 15. Yay! I am Christina Choquette. I'm the VP of Operations at VITL, and I am very, very pleased to be moderating this section of hot topics in meaningful use. And I know everybody's on the edge of their seats about this topic. I'd like to also introduce Suzanne McEachran. She'll be our panel facilitator, which will be the second half of this session. In the beginning part, we will be having two presenters, Matt Fisher, and I will be introducing him right before his presentation. We do have on the line Tom Novak, and he'll be your first presenter. He is from the Office of Policy at the Office of the National Coordinator for Health Information Technology. Tom first joined the ONC as the Director of Delivery System Reform in the Office of Provider Adoption and Support, or lovingly known as OPAS, I guess. He coordinated the aggressive support for the implementation of Meaningful Use Stage 2 via 62 regional extension centers nationwide. In July of 2014, Tom moved to the Office of Policy in support of state-level interoperability initiatives. And his presentation will be more focused on that exchange and interoperability.
All right, well, good afternoon, everyone. I am now, it may be a little confusing looking at my intro there. I work for both. I'm doing a part-time detail with CMS on the Medicaid system side. So now, you know, when I was with CMS the first time, I could blame all the meaningful use problems on ONC. Then I was with ONC, and I could blame all the meaningful use problems on CMS. Now I have nowhere to run. It is all me. I now literally work for both. So I'd like to take an opportunity, and Vermont is well aware of this. Vermont was one of the early states that got very aggressive with ways to use some of the federal dollars to support interoperability. And we all miss Hunt Blair dearly, and he was one of the, probably the driving force behind this ambitious goal. And, you know, I personally knew him well. He was a great leader in this area, and because of his leadership, Vermont was able to submit the first, what we would call a jumbo IAPD, which is basically requesting money from the federal government from like 5 different pots of money that go towards this sort of grander vision of supporting interoperability in the state of Vermont without the typical sort of silos that you might otherwise find in the sort of Medicaid CMS relationship. So a very visionary approach that united funding streams for the Affordable Care Act's new eligibility processes, combined with the state MMIS program, linked with health information exchange activities, all done in a very holistic approach that I think was ambitious and remains one of the leaders in the country in terms of interoperability. Since that time, with Vermont and Massachusetts being some of the early leaders in some of these aggressive projects, we have since had 33 other states follow in the footsteps of Massachusetts and Vermont, and they are now all seeking federal dollars to support these interoperability projects. And these projects are basically anything that helps a Medicaid provider achieve meaningful use. And thinking about meaningful use, thinking about what kinds of activities that involves, it's transitions of care, drug-drug reconciliation, summary care, view, download, transmit, consumer involvement and consumer engagement activities, secure messaging. So all these sorts of things can be supported by a federal state match. So that match is 10% Vermont funds matched by 90% of federal funds. The requirements for what can be supported are in a few state Medicaid directors' letters. And Vermont, among other states, were really the leaders in reading these letters, sort of taking them back to the state Medicaid agency back to the governor and other state leadership and saying, okay, here is what is available. What can we do in this letter to support Vermont? And other states have followed suit and have taken this similarly aggressive approach to looking at ways to support health information exchange across and doing various activities. I would say, somewhat oversimplifying, that this partnership with CMS and state Medicaid agencies either supports onboarding or architecture. The first bar is sort of onboarding, and that's intentionally ambiguous. Onboarding is when we will work with a group of providers, and often we let the state Medicaid agency determine which group of providers is in most need of connection to the health information exchange. Various states have very interestingly identified different clinical populations. So it's sometimes public health officials, or sorry, public health providers. It is sometimes pediatricians, dentists, basically providers who the Medicaid agency determines have a particular need for connection to a health information exchange, but where they find there is a lack of maybe regional extension center presence wasn't there to support them, or the state itself wants to do something similar to a regional extension center and go after these providers and help them. And the onboarding might include the technical as well as administrative steps of connecting to a health information exchange. So it might include the sort of administrative steps of looking at the business associate agreements, looking at the encryption standards between health systems, signing the contracts, looking at all the HIPAA disclosures and the consents and making sure that it's all aligned. And then the technical components of onboarding, like looking at a direct address and setting up a direct mailbox, and the other sort of more technical encryption work that might be involved with building a health information exchange. And then some of the other funds are used more for architecture purposes, so building, say, public health interface or various nodes or use cases to a health information exchange, say a provider directory or secure messaging, sort of a back end of direct messaging, or other services, maybe a master person index, or maybe ADT alerting for encounter alerting. As well as just sort of general planning, like research as to what is needed and do some business process modeling. So we've had some very aggressive activities undertaken, and states are really being experimental, and again, Vermont's sort of at the front of it. What we are further encouraging is thinking sort of more broadly about some of the other possibilities. We really, really want states to get creative with what they're asking for, with what can be done with some of this support. Public health in particular is historically underfunded. We have had other states ask for things like working with a cancer registry, which is very nascent in terms of partnership with Medicaid and CMS as well as ONC. So we're working on things like that, or some opioid treatment programs, utilizing the prescription drug monitoring program as a use case within a health information exchange. So we're seeing more and more of these sorts of partnerships develop that are innovative, as well as a very sort of sound investment and an appropriate use of these federal funds. Some of these infrastructure activities are the first of their kind: the Master Facility Index, patient matching algorithms, like new and better patient matching algorithms. There are situations where we could do data loading, and that sounds sort of general, but what that really does is an opportunity to use Medicaid as a way to give value to a health information exchange. So if you think about your health information exchange, and the state is looking for willing partners, there needs to be data in it, right, for other payers or other health systems to be interested in partnering with it. And Medicaid data is rich, and a state can use some of their federal dollars to load the health information exchange with provider directory information or master person index information or master facility index information. And then if you're selling your health information exchange, you then have a product in there. You already have some sort of richness of data that will only be further complemented by your new partners in your health information exchange. I don't need to read through everything, and these slides are going to be available a little more on pre-planning analysis, because I think this is also relevant for Vermont. I know you're in discussions about this. So with the High-Tech Act, one of the requirements was that the state create a state Medicaid health ID plan, known as the SMHP, for those of us who deal regularly with the documents. And the SMHP has a section called the environmental scan, which the front end is a examination and analysis of the EHR adoption within the state and the interoperability within the state. And it looks at things like broadband. It looks at various levels of adoption by a provider. And it also looks at obstacles. It looks at maybe there's a demographic obstacle, maybe there's a geographic obstacle, maybe a certain health system is challenged, or maybe all of users of a certain EHR are having a difficult time getting to meaningful use stage 2. So it sort of looks at all these various barriers. And where we are right now is that every state did this when they first entered the program, the Medicaid high-tech program. It's now time to sort of refresh those and get new information. And we are finding that we have much, much richer data out there, and we can make much more data-driven approaches to looking at our adoption challenges within the state. And the state can, again, use some of that 90-10 federal match to assess their state and see where there might be room for encouraging adoption with very targeted outreach to various providers or areas that they find are underserved in EHR adoption or in interoperability. So we're trying to sort of increase the quality of the environmental scans. The environmental scans in the beginning were often done through just state surveys by state associations. Now we're finding that we have so much richer data with the Regional Extension Center program and sort of more more robust state Medicaid agencies having sort of more comprehensive presence in health IT and high tech. It used to be just Hunt and Terry were the only ones there. Now I know we have Lorraine. We have a lot of other people doing very good work in those offices. We can really do more with understanding the state landscape. So don't believe everything you read. Things are improving in terms of exchange and meaningful use stage 2, and we are getting there. And your regular reminder, this program is only half over. We're still going to 2021. So exchange is increasing. We are seeing the needle move. We are seeing the same barriers that many of you see. We have been tracking this diligently, and we are safe to assume always working on new ways to overcome some of these obstacles to adoption and interoperability. I think maybe you might have just seen our interoperability roadmap, which just came out, and I think it's been discussed elsewhere. We are also successful in a lot of our sending and receiving and using the data. We're very encouraged by that as we track a lot of those figures. We're seeing that the data is flowing. I think our health information exchange funding was troubled in some ways, but it has made data move. It is getting there. It was obviously imperfect. We don't have as many health information exchanges as we would like up and running and sustainable. But we are, I think, approaching this with other initiatives we have cooking, a spot hopefully where we are going to hit that tipping point. And all signs sort of are encouraging, particularly when taken in tandem with the interoperability roadmap. And if I'm going too fast, I believe, or did I repeat this? Maybe I repeated it. So this is sort of the bright, shiny future that is sort of my favorite part of looking at health information exchange, which is when we first began looking at health information exchange as part of high tech, it was just that. It was a sort of narrow part of high tech, and no one else was really thinking about health information exchange in states outside of the tiny high tech office. What we are now seeing as we have the Affordable Care Act, we have more and more interest in all of these new care models as we have to track a patient across multiple care settings. We have interest from all parties of new ways to do this. What states are doing now is they're going beyond the high-tech program. They're looking at their MMIS system, which, the MMIS system is a richer source of funds. Because not only do you have the 90-10 funding to begin with a project, in the high-tech world, that 90-10 money runs out. In the MMIS world, it moves to operational. So you actually continue to have funds that are a 75-25 federal and state match forever. Like it's an operational funding, and that's for systems and automation. And then you also have a 50-50 personnel match that goes on forever. So in many ways, it's more sustainable. And state MMIS systems, as well as on the high-tech side, we're really encouraging systems to be amazing. Like provider directories are rather immature if you look at them as they are, which is not to say that the entities that have provider directories aren't trying, but there's a lot more we can do that we are seeing more and more states attempt. For example, many states looking at your provider directory, it's at its most basic level, a white pages of clinicians where one clinician can look up another clinician and send a record, right? And it could be just a text, or it can be a structured data. What we're seeing, though, is that as you look at the other clinician, what is most obvious is that you're going to want to have data elements such as board certification, any sanctions, when are they due to take their boards, where do they do their fellowship, licensure status, things like that. And that information almost always lives in public health. As we have discussed, public health is historically underfunded. So one thing we realized we could do very easily and within scope of all this funding is create provider directories that have a bi-directional connection to public health, so that the clinicians can connect back and forth to public health back and forth to the provider directory. So if you're a provider going onto the provider directory, you can use a dynamic provider directory to submit information to a registry, any registry. You can do secure messaging via it. Care plan standards are sort of immature, but there's no reason you can't put care plan exchange from provider to provider within a provider directory. Alerting could have a role in a provider directory where you can push electronic messages whenever there is a change in encounter status for a patient via a really, really good provider directory. And again, the best thing about that is that provider directories are supported. They're supported by MMIS, they're supported by high tech, and they aren't as subject to as rigid cost allocation requirements in the MMIS or in the MMIS world versus the high tech world. We're also seeing states get very inventive with Top Health, one of our open source tools. What they're doing is, Wyoming, for example, they have taken Top Health. They have assigned some developers to sort of open up the hood, which you can because it's open source, and they retooled it to make it a provider-facing quality reporting tool. We've had several states now sort of pick that up and run with it, look at it as a provider-facing quality reporting tool that can spit out a QRDA3. You could have spit out a QRDA1, but that's not really something we're using. They could do self-attesting, and my apologies if not everybody knows what a QRDA3 is. It's basically the quality report that is standard for most meaningful use purposes. So we're seeing some of these open source tools become more and more prevalent. And again, we're really going beyond high tech. Let me just hit on clinical data warehouse really quickly, because that's also something that can be supported by in the MMIS world. But if you think about what a query exchange is, a query exchange is also just a query you run against a clinical data warehouse, right? A clinical data warehouse that's sort of dynamic and fed in real time or near real time. So clinical data warehouses, again, are supported by MMIS funds. So we're finding more and more states get inventive with the way they structure themselves. And in many ways, based on Vermont's example, to look at how to build a state Medicaid enterprise that is sort of future-proof and ready for the new challenges of new care models. And again, with the move towards all these new care models nationally, we're finding states getting sort of more and more clever about how to support interoperability. And I don't remember off the top of my head the managed care presence in Vermont, but what we're seeing some states even do is, since Medicaid is the one doing the contracting for managed care organizations, for Medicaid HMOs, or Medicaid MCOs, what they're doing in states like Arizona and Louisiana is they're putting in their RFP for state managed care organizations a requirement to participate in the health information exchange. And that requirement is detailed. It says if you are a payer that wants to do business in our state with our Medicaid population, you have to do the following to help treat our patients. And it will include things like submitting encounters to an ED registry, or supporting statewide alerting across the payers, supporting care plan exchange, or supporting transitions of care as a patient moves from one plan to another, so that the new plan has, within their case managers, they have access to the summary with the patient history, the problem list, the drug list, the care plan if applicable. So the payers out there who are doing work in the Medicaid managed care world are the biggest payers in the country. Like it is the the Uniteds and the Aetnas. Like this is a huge chunk of their business, and we are pulling them in using some of these levers, and it's been effective. They're certainly responsive. It's early, so we still haven't seen completely how it plays out. We are learning a few best practices. So you can't just sort of push in all the payers. You also have to loop in the hospital systems often to make sure you have a really sort of broad coalition of stakeholders. But these are some of the moves that we're seeing states make. We're very encouraged. And what I tell every state that I speak with, and what I would like to, again, emphasize is basically ask us anything. If there's an idea that the state has for something innovative they want to do with health information exchange, something maybe that's never been approved elsewhere, go ahead and knock on our door. Send me an email. Send CMS an email, and let's see what we can do, and let's see sort of which bucket of money this might be best supported by. If there's a way to design it that is sustainable or more sustainable than another way. If there's a way we can incorporate it into some sort of existing rubric. So we really don't ever want any states to think, oh, CMS will never approve that. We're not even going to ask. Always ask us. Always approach us. And that really goes for like everybody. That's not just the state Medicaid office. I mean, there are stakeholders in the room who have ideas, I'm sure, about telehealth or about consumer engagement or sort of other things that are maybe a little bit outside the sort of general understanding of a health information exchange. But it's a conversation worth having. Like it's worth digging into the weeds and seeing what we can and cannot support. So with that said, I don't know how much time we have for questions, but I'm available for questions. And I can wander outside this topic a bit. I can't really talk about any regulations. I can tell you that we're working on it. I can't give you any days when anything is gonna drop. But I am sensitive to any anxiety about the reporting periods and whatnot, and we are well aware, and we are trying to make sure that everybody is accommodated. So that said, I'm open for anything.
Great. Thank you, Tom. Actually, I'm going to ask if people would please hold their questions until the end because we do have a panel. And yeah, that's okay, Tom. Because Tom, you're still going to stay on the line, correct?
Sorry, yes, I am staying on the line.
You are going to stay on the line. Okay. And then we can incorporate any questions to everyone who will be on the panel for Tom to answer, as well as for Matthew, who is our next presenter. And Tom, I'm going to leave the go-to meeting up so that you can follow along with the bouncing ball, but I will take the presentership back from you because I think I have the power to do so. Yes, I do. So our next speaker is Matthew Fisher, and he is the co-chair of the Health Law Group and an associate at Merrick O'Connell. Matt focuses his practice on health law and all areas of corporate transactions. He advises clients on meaningful use-related issues, including incentive assignments and compliance. Matt is the chair of the American Bar Association's Health Law Section's Web and Technology Committee. So I'd like to invite Matt up.
Well, thank you. Good afternoon, everybody. Very happy to have made it up through all the rain. Hopefully everyone else had an easy trip or not too bad of a trip. So it might move. There we go. So I'm going to focus on some of the legal issues that I'll typically see connected to meaningful use. Kind of my view on it is, I'm going to take 4 main topics that are identified. So assignment, audits, patient engagement, and interoperability. I think you can kind of look at it as breaking down into 2 different categories. The first 2 are kind of, in my view, maybe older legal issues that have probably applied since meaningful use came out. Whereas looking at patient engagement and interoperability, those are kind of newer developments that are, as the program has progressed and is growing. And I think it really kind of ends up tying into a lot of what Tom was mentioning in terms of the implementation and development of the health information exchanges. You've got these issues popping up. So for the assignment of benefits, what are we talking about? The assignment you're looking at is the fact that when you're talking about meaningful use, a lot of the money is really tied to eligible professionals or eligible hospitals. But thinking about the eligible professionals, it ties to that individual provider. It doesn't, if they're employed somewhere working at a group practice or a hospital, if they're testing for the eligible professional, it ties to the individual. So the individual has the right to the money. I've actually been kind of dealing with this issue with a client of mine who's a solo practice physician concerned about getting currently certified EMR into place so she doesn't end up getting a penalty going forward. But that highlights how it ties to the individual. It doesn't go to the employer automatically, which is why you need to have an assignment provision in place. And this was something that was highlighted within the regulations, although the regulations mostly punted it to the parties. The government didn't want to have to step in and be a part of determining how that money would flow. So the regulations just said the money can be assigned, which is fairly consistent with a lot of what happens with employed providers. You can think of it as very similar to what happens for a physician who works at a group practice. They're assigning the benefits, the Medicare benefits that they receive for seeing Medicare patients, so the reimbursement that they get for those services, they reassign to the employer. So this would be a very similar scenario. So even though I just said the regulations leave it alone, they do provide a couple overarching guidelines to keep in mind. The key one there is that you can only assign to one employer or one entity. It might be that a provider works part-time at a couple different places, but they can only assign the benefit to one employer or one entity that they're working with. So you want to be very careful in terms of whether an assignment has already occurred. If that has happened, for example, if you end up switching employers, you probably want to end the assignment to one and move it on to any future payments to a new person or to the new employer. So with the very bare regulatory background out of the way, what are some of the actual practical ways about going about and doing the assignment? Because as I said, it is for the most part a private contractual matter between that eligible professional and whoever they're going to assign it to. So kind of running through the questions on the slides, thinking about what's the first one you want to do. You want to think about where is it going to go to. So when the meaningful use money comes in, who's it going to go to? Should it go directly to the employer? Should it go to the eligible professional? Is it going to be split? So is it all the money goes to one place, or is it only a portion of it? These are kind of the issues that you'd want to hit or address before the money comes in, because obviously, if the money has come in and there's no assignment provision, I would tend to doubt that whoever has that money in their pocket is going to be willing to give up any portion of it, because money received is money spent in most cases. Then the question is, if you are going to split the money, how are you going to split it? As I said, is it that 100% goes to, for example, the employer that actually assists and provides all the data for the attestation, or does the eligible professional get to keep some portion of it? I think the biggest one is what actions will be required of each party. My expectation, and this is probably or at least in my view, the reasonable expectation would be that if you have an eligible professional working for a larger provider, it's like, for example, one of my main clients is a physician group that has 300 plus physicians. Clearly, they have a lot of administrative structure in place, and they're the ones actually tracking all the information. They're tracking what's going on in terms of usage of the electronic medical record, all the patient visits, all that patient information. They're the ones who are compiling the data, running all the calculations, and doing everything that allows the attestation to be done on the part of the eligible professional. The question would be, if you're at a smaller practice, who needs to provide assistance? Can it be that you have administrative staff that can handle all of it, or does the provider need to play a role in it? So I think when you're thinking about the contractual language that you'd be looking at, you'd want to build in that expectation of each party's responsibilities. Kind of the key from a contracting perspective is you want to try and think about and address as many of the problems as you can ahead of time. You want to set the expectations of the parties and avoid any fights down the road, because if you have to fight down the road, that can get time-consuming and costly for everybody. Somewhat of a newer issue, and one that I think brings up a lot of nuance, is what happens really nowadays. It's probably a matter of when, not if, the eligible professional leaves the entity that they had initially assigned their benefit to. So one question is, what happens if you leave in July, so in the middle of an attestation year? Is that professional going to be able to get the data that they had put into the EMR for the first half of the year and bring it over with them to the new employer? Will the former employer still provide assistance in terms of compiling the data and putting together reports that might be needed to support an attestation? Will they be willing to share that with a new employer? Because arguably you're going to have competitive information or that could be included in there. Trying to address that after the fact, once someone leaves, is going to be very difficult, because most times, not most times, but sometimes it could be that you have not the best parting of ways between parties, and you might not have cooperation readily available there. But if you have built that into a contract, then it helps to, again, set the expectations and set the ground rules for what's going to go on. And it allows people to fall back and just say, okay, well, there might be hard feelings, or even if there are good feelings about how it went, there are clear rules in place in terms of how to address what you're going to do. Another question that I've seen come up with the assignment is, where do you actually do it? I remember for one of my clients a few years ago when they all of a sudden realized, wait a minute, we need to get all this money assigned, otherwise we've done all this work for our employees for free and they're just going to walk away with the thousands of dollars even though we paid for the EMR. The question is, again, where do you put it? Do you put it into a standalone agreement, so something that just addresses the assignment of the meaningful use money, or do you build it into the employment agreement? In my opinion, I don't think it matters which way you do it, again, so long as you do it in a clear manner. I might, to some degree, lean in favor of building it into the employment agreement for the eligible professional, because one, that means you're not going to forget to do it, because it's part of a larger agreement that Wearing one of my other regulatory hats, you better have in place. You generally do not want to have an employed physician without or an employment agreement or some other written contract there. But again, if you build it into the employment agreement, then it's set there, you know it, you have the understanding that it'll be there and everyone will be able to see it and you won't forget to end up having it executed. Although one thing to keep in mind there is as the rules change and circumstances change, continually look at the language of the contract and make sure it's up to date and meets kind of what is going on. So kind of that, as I said, that was kind of the brief overview of assignments. The next one, which is another key issue that I think has, again, been around since the beginning of meaningful use, although didn't start coming up until a year or two in, which are the audits. It was very nice to meet Vermont's auditor. I'm going to focus probably more on the Medicare process, which is the one that I'm a little bit more familiar with. I'll be honest, I don't know the Vermont rules very well. On the Medicare side, you've got Figliozzi and Company are the ones who were the contract. So if you get an audit from them, typically you'll get a letter. The ones I've seen are usually about a page long, just saying provide us support for your attestation of X, Y, and Z elements that are identified, or just provide us with support for everything that you've attested to. The attestation is going to tie to the people who are being attested for. So, again, talking about one of my clients, they had, I think earlier this year, they got about 50, 60 letters for 50 or 60 separate individual physicians because it was their employed physicians really on an individual basis are the ones who are attesting to get the money, which is why they got the individual attestation letters. I'm not going to lie, being audited can be a very stressful process. It can cause a lot of concern and worry. However, the best way to deal with that is don't let it sit. Address it as soon as you see it. You don't want to end up being with a day before the deadline of when you're supposed to be providing the requested information, all of a sudden calling up for the first time and saying, hey, I got this letter, a month ago and I just haven't done anything with it, but can I get an extension? Or, what are you really looking for? It's, the best thing to do really is whenever you get any type of letter is, one, figure out if you have an internal committee or organization that has been set up ahead of time to address audits when they come in, but run it through the proper channels and then start dealing with it as soon as you can. And also another good thing, and this kind of, in my experience, applies for most government investigations, is reach out to the people that are auditing or investigating you. Open a dialogue and show that you want to be cooperative. That doesn't mean that you're going to be providing everything, because you might justifiably want to withhold things, or you might have things that are protected by, for example, the attorney-client privilege. But open a dialogue so they know that you understand the process, and then you can maybe even also try to narrow the scope of what information is being looked for. One key thing to remember is when can it happen? I know that you can have prospective audits, although I've not heard about too many of those yet. The bigger one are the retrospective, and the thing to keep in mind there is the time frame, which is it can be up to 6 years after the fact. So how do you prepare for an audit? Obviously, you never know when it's going to come, but the biggest thing about the audit is be prepared before you even attest for meaningful use. What that means is clearly you're going to be preparing a lot of documentation and support for the attestations you're going to make. Keep that documentation, don't destroy it, make sure you have copies of it. It always seems counterintuitive to me, but to support the meaningful use attestation, it seems like you're generating a lot of paper for something that's supposed to be creating an electronic usage. But you want that paper because I've heard a lot of stories about, oh, we got an audit, we didn't keep the support for our attestation, and now we can't generate the same numbers that we did when we attested. If you can't do that, there's really not much you can do. You're going to be kind of up the creek because it's, you've attested and now you can't show that was a truthful attestation. So again, as I said, you want to maintain the documentation as you're going, which also ties into have a plan in place ahead of time. have key people in place who are going to be in charge of maintaining that information and who are going to be in charge of keeping it organized. A community hospital that I work with, I believe I think it might be their security officer, their HIPAA security officer, who ends up tying into a lot of it. But she has like a 3-ring binder that thick to back up what they've done. So that way, if they get an audit, she knows exactly where to go, and she can call up the heads of the right departments and can have the appropriate information there, which then runs into, again, it can't be said enough, is document, 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 keep it. The last thing I would suggest is, and this can be helpful, is to do mock audits. So it's clearly known kind of now what an audit will look like, especially on the Medicare level, because you can find sample letters, people have written blog posts or articles about it. So you can perform your own assessment, maybe do it before you attest. So you can say, okay, do we have everything in line to be able to back up what we're saying? Kind of the one thing that I would think about, and this kind of applies in a lot of circumstances, especially in the healthcare arena, when you're looking at whether you've done things appropriately, is do you want to run these things through your attorney? I know this is going to kind of sound like a self-serving advertising statement, but if you have your attorney kind of hire the consultant or run that audit for you, you can probably cloak that in the attorney-client privilege, which means you don't have to share it with anybody. It allows it to be your private communications that you've obtained for, obtaining legal advice or getting legal assistance, which, so if you do get the audit, you don't have to reveal the results of that mock audit to show, oh, we did fail something, or have to show what you've done to try and improve what you're going to do. So it's, again, it's something you always want to keep in your mind in healthcare, especially because there are many opportunities for people to try and second guess what you're doing and try and get money back from you that, in my opinion, a lot of times has been rightfully and properly earned. So hopefully you don't get to the stage where you've done an audit or you're audited and then end up failing for some reason. But if that does happen, at least on the Medicare level, again, there is some limited appeal process. Unfortunately, there is not very much that can be said about it. It's, as the slide shows, there's really only 5 categories that you can think about when you're trying to appeal. Keep in mind very carefully that 30-day deadline. That'll be in the determination letter you get back from the auditor. If you miss that 30 days, so if you try and submit on day 31, that's grounds to reject, and it's likely going to be rejected. But it's, at this point, still very much a black box in terms of what the appeal process and appeal outcomes are. I'm not sure I'm even aware of the outcome of any appeals. And in terms of the process, it's just, as I said, it's just very ill-defined, and unfortunately, I probably don't expect to see much guidance on it. So it's, to some degree, unfortunately, a feeling out process. So now kind of moving into the first area of what I'm going to call the newer issues, this being patient engagement. Clearly, this is I think very much a blossoming and blooming issue. It's, I'm fairly active on social media, and I remember when the modification proposed rule and the stage 3 proposed rule came out, it was all over Twitter because of the changes, especially in the modification to reduce the current level of patient engagement required, especially on the patient portal side of things. So it's definitely an issue that's on the mind of a lot of people, because you want to be, the whole goal is to try and get the patient into the dialogue of care. From my opinion, that's really what care coordination is, and where we're trying to go in terms of a shift to a quality-based system, is everyone has to be involved. So from the patient engagement side, at least for me, the areas where you'll have some legal issues are the application program interfaces. If that's going to be a way to go for your patient portal, does that mean you're plugging in a third-party product onto your EMR or some other solution? Secure messaging, and then the incorporation of patient information, which is clearly the result of all the wearable products and different mobile apps that are developing. So thinking about these, what are some of the overarching concerns? Obviously the biggest, and the first two bullets definitely go hand in hand, are about privacy and security, and then HIPAA. To me, those are the biggest issues. Clearly, privacy and security are at the tops of everyone's mind, because really, it's not if you're going to be breached at this point in time, it's just when. It's really, in my opinion, impossible not to get breached, because if someone wants to breach you or access, inappropriately access your data, you're not going to be able to stop them, because the people who are doing that are just well in advance of the defense around it. It's my understanding that's kind of always been the way it is. It's, you find the attack and then you develop the defenses afterwards. So with that in mind, you still can have appropriate security in place. This kind of leads into why it is essential to be doing your HIPAA risk analyses as well as the meaningful use risk assessments. So you can adapt your policies and procedures and also your actual protections to the changing world. The one thing I always like to say is probably a year or so ago, or a little over a year ago, no one would have put hacking at the top of any list of security issue, but now it's probably the #1 issue. So the world is always changing on that side. And then tied to that is your contracts with your outside vendors. If you're going to be using people to support you in these programs or developing the tools, have the appropriate contractual protections in place. This will kind of lead into the secure messaging, but I have a new client that's is developing a secure messaging platform that's intra-facility. So within the different sites of a hospital system or between providers, and it's one of the things I said to them is, even if you end up pulling data that's arguably not technically protected health information, everyone's going to expect you to hit the the HIPAA standards. It's just, you're not going to avoid it. So it's but if you're from the facility contracting with someone like that, you want to be able to ask them you want to ask your vendors the right questions. You want to do your diligence on those vendors and not just blindly enter into an agreement and start having them do work for you. So specific concerns for some of these components or some of these issues, just to reiterate though, each of the big ticket items that I hit on the last slide definitely apply to each individual item. But again, from the API or patient portal, if you're redesigning it, again, who are you using to do it? Is it potential that you're doing that internally, or are you using an outside vendor? If you're using an outside vendor, what information are they getting access to? If they're going to be using or accessing any of your PHI, make sure that you have a business associate agreement in place and that they actually meet the standards that they say they are when they sign that. Another thing is, and this is obviously an ongoing issue with the patient portals, but how are you encouraging your patients to actually use it? How are you communicating its existence to those patients? Is it the front desk or front office people who are checking in the patients, and it's kind of a checklist item when they're checking the patient in? Is it the provider who's doing it within the visit, saying, oh, I'll post information, maybe your lab results or something in here, and sign in to get it? Or are you sending out flyers? Whichever method you're using, if it's in person, face to face, it's less likely to cause a concern. But if you're sending out flyers, could that constitute marketing? And if it's marketing, are you complying with the HIPAA marketing rules? Are you have people asked not to receive things like that? So there's a lot of interplay in terms of looking at what you're doing there. And then the last piece is, if you're having an outside third-party vendor develop that new API, how does it interact with the EMR? Can they actually develop something that can plug into it and not cause a system to crash or cause the system to malfunction? Or also, one thing to keep in mind is, look at your contract with the EMR vendor. Does that contract prohibit you from having a third party create a program or an application that's going to interact with that piece of software? A lot of contracts, especially when it comes to licensing software, and it's either, most EMRs, if you're hosting it locally, you're licensing the software to use it, or if you're accessing it on online, if you're getting it down from the cloud as software as a service, a lot of those contracts will try and lock down in terms of how you can modify the software or what you can do to build onto it. And the other thing to keep in mind is if you make something that improves the functionality, the rights might automatically flow to the EMR vendor. So, even though you paid the money to do it, to have a solution built or to improve the EMR from your perspective, you might not own it. And you might not be able to, try and sell it off because, we have one client where they were, I believe, looking to make improvements to Epic to try and improve their functionality for it. And it was a very fine line in terms of when that defaulted to an open license for Epic to be able to use and everyone in the Epic community could use it, or they could maintain full rights, where my client could maintain full rights and then be able to market it and be able to make money off of it. Secure messaging, I think Tom was touching on this in terms of it can be a functionality within the HIE in some places, but the one thing to keep in mind is secure messaging, if it's done well and done properly, it is a great tool, but if it's not and there's just representations that it's going to be okay, you could have a major HIPAA risk, because if the appropriate security is not in place, then you're just sending unsecured PHI around that if it gets out is per se going to be a breach. So again, just think about how you're going about using it, who's providing the solutions, and what they've done to make sure that that messaging is properly secure. And then I think the last patient engagement piece, which is definitely a growing issue and one that I think has not even come close to becoming what it is the patient-generated information and incorporating that. I know that's part of the stage 3 proposed rule, is to incorporate patient-generated information. This is going to open, I think, a whole host of issues. From one perspective, how accurate and reliable is that information? Say the person's trying to measure their heart, their blood pressure, or any of the other measures that an Apple Watch can do. Does the clinician actually trust that data? Can you independently verify it? Do you know how good it is? Because I feel like I've seen some stories recently that said a lot of the wearable devices on the market, overstated the accuracy of the data that it was collecting. So it's, that's already calling into question some of that information. And then once you collect that information, what's done with it? Is it just that you pull it in and it gets stored somewhere and is never reviewed? Or how do you go about verifying that the provider is going to look at it? Kind of stepping outside the meaningful use world, if you get information from the patient and it shows, maybe some arrhythmia or some other, could hint at an underlying issue, but it's never reviewed, but you're saying, we're taking this data and we're incorporating into the record, now you're creating liability because you've received, arguably the providers received notice of a health condition, has not done anything about it. If there's an adverse outcome, you could have a professional liability on your hands, or professional liability issue on your hands. So it's, I think there are a lot of issues to explore on this front, and it's something that is certainly going to develop over time, because I don't see, individual generated information going away, and I think there's a growing push to have it utilized, but it's, I think it requires a dialogue on both sides, from the individuals and from the providers, to understand how to utilize it. So then to move into the last legal issue that I wanted to touch on, which is interoperability. And I know, again, this was a topic that came up in Tom's presentation, but for the first thing, what does interoperability actually mean? If you've seen one definition of it, you've seen one definition of it, which I know is a statement that is said a lot for a lot of different things in healthcare, but it really does seem to mean different things to a lot of different people. Meaningful use does set out certain standards that it perceives qualify as interoperability. I don't know if it's necessarily the popular conception of what people are necessarily have in mind when you are just kind of discussing it and around the water cooler or not. But so meaningful use has the one perspective on it. To some degree, I think it's a little bit narrower, but it's really on a basic level, what you're thinking about with interoperability is having information flow back and forth and have it go across different systems, or at least that's what it means to me. I think you really want to have that information freely available. So how do you go about doing that? I think state health information exchanges are a very good way to get the information going. Although you want to think about the particular rules of the exchange in every single state. I'm more familiar with Massachusetts, and for Massachusetts, we call it the Mass Highway. You actually have the patient opt into it. It's not, you can't just post the information into it, but you have to specifically give the patient the chance to choose what they want to do. So it's, when you're thinking about where to put it, you want to be very careful in terms of how you're doing it. So I think some of the key issues are, what do your particular systems allow? So that kind of one goes into an area of who owns the data. I'm aware of some EMR contracts that say the EMR vendor owns the data. I remember, I think it was maybe 2 years ago at this point, I think it was a provider in Maine, fell behind on their payments to the EMR vendor. EMR vendor shut off access, and all of a sudden that provider had none of their patient data. So you really want to pay attention when you're contracting who owns the data, because one, that's going to impact your operations regardless of whether or not you're trying to have it flow somewhere else. But then if you want to have it become interoperable and be able to be shared in other places, can you even do that, or do you have the rights to do that? I know there's been a lot made that with probably a lot of the focus being on Epic in terms of them not wanting to have their systems interact with others. I found a very interesting article from Paul Levy, who's a former CEO of one of the Boston hospital systems, who writes, he has a blog called Running a Hospital or something along those lines.
Right, yeah.
And he had a recent article questioning talking about the new Epic relationship with Mass General, questioning whether there were antitrust violations going on. Because what MGH is saying, okay, we're going to implement this, and everyone that we work with has to adopt Epic. That's all well and good if it's a practice that MGH owns, because if they own it, they can do what they want with it. But they were also requiring their affiliated entities. So it could be a community practice that is just on using MGH as like a managed service organization or in some other functionality. They said, well, if you want to stay in that network, you have to adopt Epic too. So, Levy's argument was that's anti-competitive because it's removing their freedom of choice in terms of what they can do, and it's forcing them to choose one thing, because they're saying, well, if you don't do this, you're cut off. And his argument was it also plays into what Epic does, which is lock down its system so it does not talk with anybody else. I don't know. I'm not going to comment on the legal merits of that argument. But if it's true, it could be potentially troubling. And that's why I think, if you want to have true open interoperability, I think you're either going to have to push for legislative change, which means, unfortunately trying to get Congress to do something, or, there could be lawsuits, because sometimes it can be the courts will move faster. And then this also puts the recent report about information blocking, further under the bright lights of the public. It's, I think people in the HIT field have probably been aware of it for longer than the general public. But once the general public becomes aware of it, then I think it's, easier to maybe be able to push change. So, just a few quick summary points. Overall, in my opinion, compared to other areas of healthcare, meaningful use doesn't necessarily present as many legal challenges as other areas. But that doesn't mean you should ignore things that are there. There are some nuances, but the one thing to really keep in mind is be prepared. As you're going through each stage of the process, think about what you're doing, think about how it connects to the bigger picture, and maintain that documentation. And then also, I see meaningful use and HIPAA have a lot of cross-pollination between them, and it's I think some of the meaningful use requirements feed into what you can do to be meeting your HIPAA requirements. So it's don't lose sight of the larger picture of HIPAA within that. So that concludes the key legal issues. So I will turn it back over.
Great, thank you. Okay, thank you. I'd like to give a round of applause to both of our presenters for being here. Thank you. So, boy, I really love having an attorney in the room because it's always lions and tigers and audits, oh my. But some really great information was shared. You bring up a really good point about if you have an EHR, who actually owns the data. I too heard that story and it was quite frightening. We at VITL have been partnering with certain organizations about information blocking, so yeah, that's on the top of our minds. Tom had some really great points about the APD process, which I have been involved in trying to get some money along with the Department of Health Vermont Access in order to implement some really creative ideas to keep Vermont ahead of the curve in interoperability. So again, really great information. At this time, what I would really like for you to do is just start jotting down some questions. We're going to take a very, very short break. I don't know how much time we have left here. It is, we have about 50 minutes. So I'd like maybe just to take a couple of minutes while our panel comes up, get settled. I'll introduce them. And so talk amongst yourselves.